Thanks for coming. So I'm going to basically talk to you about what we do in our IVF unit. We're based right in the middle of the UK, so just a little bit above Birmingham. This is our group called the Fertility Partnership. This is the biggest group in the UK now. We now have 8 clinics in Europe, so we're the biggest group, just a group called Viva Neo. Don't know if anyone is from here. So there's 8 clinics now in 3 in Austria. So it's the biggest group in Northern Europe. EV is the biggest group in Europe, of course, so, but we're growing. And we have meetings all the time, so we talk about how we do things and we try to improve. So it's really good having such a good group of people. We can look at our success rates, how many eggs we collect, absolutely everything. So from the very start right through to the finish. And we do quite well. We also have a big ultrasound group, so we are joined by a group called Ultrasound Direct or Baby Bond. They had about 82 clinics. I think we're about 90 to 100 clinics in the UK now. So all of these IVF units and all of these clinics are GE based, and all of them do use 3D. So I'm going to try and run through what we do and how we use 3D to achieve these success rates. So if you meet somebody who does IVF, they always have the highest success rate. So everybody I know has success rates of 60, 70, 80%, and they're always the best, and they always teach me how to do IVF, usually over a beer. They sort of say, if you try this and do this, so which is good. It's always good to listen to opinion. But these are hard data, so the HFEA, every cycle we start in the UK, whether the lady has an egg collection, whether she has an embryo transfer, is registered. So there are proper intention to treat data from the start. So this is the national average. Just under 30% of patients have a baby, and we're about 40. So you can see the confidence intervals. So we'd like it to be higher. We probably do tell patients it's about 60, but that's where we are. So we're top 5 in the UK. We've been top 5 for, 20 years, I think. So sometimes we're number 1, sometimes we're number 4. It depends if you look at ICSI alone, male factor. So you can look at the data in different ways to polish your ego, but we're doing well. So why do we do so well? So I'm going to run through a standard process, how we start our treatment, how we monitor, a little bit about egg collection, embryo transfer, and then just finish off very briefly with a little bit of pregnancy. So the first thing to say, and I always say this, is that because we're talking about 3D, we use 3D every day on every patient. And again, I'll explain why. It's not because we have to. So most of our diagnoses are done in 2D. And as you'll see, most of our procedures are in 2D as well. But we use 3D for other reasons, more for diagnostic confidence. So I think that's a really important message, because if you hear, you have to do 3D and where's the clinical benefit, the proof, most of us are still using 2D as our primary tool. So we think of 2D as our screening tool, and 3D is if we need it for extra diagnostic confidence. I'm going to prove to you that works. So just a little bit, this is probably the most important part and half of the talk, is pre-treatment assessment. So most of the diagnoses, fibroids, endometriomas, hydrosalpinges, can be made very easily. They're not difficult diagnoses. Dirk is here, so IOTA have shown very clearly that you should be able to differentiate between a hemorrhagic cyst and an endometrioma with 100% confidence. I think we're close. I think a lot of ultrasound is actually getting the basics right rather than the real difficult cases. But in some cases, you will still be uncertain, and you'll need a second look or a second scan, and that's where 3D can really help, because it's giving you these different views, the 3 views, and it's also giving you more information about depth and texture, and that could be really important, for example, when you're looking at the myometrium. So if you're looking at interfaces, so endometrium, follicles, it's different and a different process than if you're looking at texture, so the myometrium itself or the content of an ovarian cyst. So a few examples. So again, this is probably the most important one. We still see patients have IVF treatment who have a hydrosalpinx, and of course we know that reduces your chance of success by at least 30–40%. So you have to diagnose them, you have to remove them. You can do fancy 3D images like this, but actually the diagnosis is really quite clear. But there will be those patients where you're not quite certain. You might get the plane right in 2D, and the better you are at scanning, and the longer you've scanned, the easier that is. But if you're learning, I think that if you do 3D, you pick it up more quickly. So, and this is our tool that we use for the adnexa. So I think 3D, as you'll see, is really good for the uterus, because you've got a set plane, the multiplanar view, but the ovary is different. So actually 3D lends itself less well to the ovary because it's sort of as less of a reference plane. But here, when you're trying to differentiate between hydrosalpinx, a simple cyst, or a paraovarian cyst, you can do it again with that 100% confidence. So 80%, maybe 90% of the cases, you will say hydrosalpinx, no argument. But if you're uncertain, then we do 3D, we acquire that volume, and we will use TUI to look at it. So if I've been in clinic or I've been operating all morning, and then at lunchtime we have a meeting, so we've scanned probably 30 to 40 patients. Some of those patients will have pathology. So rather than me having to go to the machine or to see a printed image, we go onto the computer, we download that file, and then we can interact with it. So rather than me just seeing an image, I can manipulate the data set and make the diagnosis that way. So that's really, really helpful. You can use 3D, again, we've used it quite a lot. We've always tried to get 3D in. So we've tried doing 3D and 4D hycoses, and they look quite nice, but they're hard work. I don't know if it was Thierry here. You just, again, a really basic, good 2D scan is all you need. And it takes a lot longer. Because the issue is, it's not real time. So even with the abdominal transducer, the electronic transducer, it's still not fast enough. And you can see here, so this is a standard hycosi. Katerina executus here, so lots of 3D and 4D images and contrast. But actually, if you're good at scanning, you can see quite quickly and quite easily. Oh, sorry, that's skipped. So you can see the dye. So a lot of this is really attention to detail, getting a good 2D image and being able to scan very slowly and very meticulously. Now, if you're new, I think this is where 3D will help. We saw a really good presentation in Singapore last year of using contrast. And again, if you're new to it and you've only done a few hycoses and you're using 3D, you'll pick it up much more quickly. So all of our new doctors, nurses, sonographers, they all train in 3D from day one. And we think they pick up 2D more quickly. So it enhances your learning skill. And then fibroids. So fibroids are really, they're an interesting thing. We had an email this morning, a group of a patient that's got lots of intramural and cavity fibroids and trying to work out the best treatment. So it's still difficult. Again, the diagnosis is often easy. So most patients are looking, have you got a fibroid? Does it affect the cavity? That's the key question we always get asked. Is the cavity affected? Because that's the most important thing. So you can make the diagnosis normally on 2D. If, again, you're uncertain, here you can see there's a large fibroid. But if you use the multiplanar view, you get a clearer view. And this is a really good example of the rendering. So here, this is just a 3D render view. Because you've got that perception of depth, you can see the different texture between the endometrium and between the myometrium. So there's a big intracavity fibroid. And again, that's what it looked like hysteroscopically. So we talk often about virtual hysteroscopy, being confident. So if you're going to operate, so I operate as well as scan. I want to know, if I've got 3 cases, I've got some laparoscopies, I want to know how complex that surgery is going to be. Have we got deep infiltrating endometriosis? So we try to make all of our surgery operative, not diagnostic. So this is a very easy fibroid to remove, so we wouldn't allow any more than 20 to 30 minutes for that. Whereas if there was a 50% involvement, we would have a different approach and maybe think carefully about who the surgeon would be as well. It's just another example of a big septum, subseptate uterus with a submucosal fibroid. So again, imagine trying to describe that in 2D. There's a uterine abnormality, there's a fibroid. Until you get in there with a hysteroscope, you're not really going to know what you're facing. Whereas if you have this image, it's key. So it's very much the way surgeons use CT scans and MRI for their operative planning. And again, this is, as I said to you earlier, about the difference in textures. You can see very clearly, and again, you don't need to use a cine loop, but it at least allows you to see it, the difference in texture between the fibroid and a polyp. So again, completely different structures. And that's, again, if you think about histologically, what are we looking at? That's why an endometrioma looks different to a hemorrhagic cyst. And the other thing, I like this is, again, this was a learning message for me, which was easy. See a polyp. We know polyps appear in IVF. It's really frustrating when someone started their treatment halfway through, query polyp. Do we stop the treatment? Do we freeze the embryos? Again, I get asked every week, at least 2 to 3 times. So if the diagnosis is clear, fine. If it's difficult, then again, I'd like to have a render view or a multiplanar view, and you can interact with that. So it's not a static image. So what I learned from this one is this polyp you can see is spherical. So that's pedunculated. This polyp, again, you can imagine if you just had this image here, the diagnosis would be there's a polyp, measures X millimeters. It's on the left side. But what does that really mean? Here, you now know that if you can see a polyp that's more elongated rather than spherical, then it's going to be broad-based, as opposed to a spherical one that's going to be pedunculated. So this is easy to remove. This isn't difficult to remove, but this is easy to remove and is going to vary a low chance of recurrence. This polyp probably needs to be resected or a very thorough curettage with a repeat hysteroscopy. So again, in our practice, we do have lots of patients who have a polypectomy and then they come back because their polyp is still there. And they're often told it's a new polyp, and it probably isn't. I don't know if you have the same experience. So same diagnosis, but a different thing. So now I don't need a 3D picture, so if I can see this, I know that there is a broad-based polyp. So again, it's 3D enhancing my 2D awareness. And this is a saline scan. We don't do many salines. I think in the UK we're a little bit behind in that, but this is an embryo transfer catheter. Just put some fluid in. I love this because you can see the different layers of the endometrium. So this is the basalis, this is the functionalis, and there's a very small polyp there, broad-based polyp. You can see how easy that would be to miss. But the reason why this is, I love this picture, is because it makes me realize, for those of you who do obstetrics, Asherman syndrome. Do you see many Asherman syndromes? It's such an issue, it's such a problem. So we have got this endemic of patients having evacs after term pregnancies, after early pregnancies, and then having repeat evacs, not being discussed about medical therapy, and they're getting bad Ashermans. So surrogacy in the UK is going massively up through the roof. And we see it again and again and again. And people talk about ultrasound-guided operations and so on. And the reason why it's so important, and again, imagine if there was a fibroid here, or my favorite thing we'll discuss, a septum. There's still, again, everyone is resecting these septums like crazy. So let's just pretend that's a septum. You cut through that, you have to go into the myometrium. If you're going to get that fibroid out, if you're going to resect the septum, you are cutting through the functionalis and the basalis. That does not regenerate, just like your retina. There'll be some endometrium that may grow over it, so it's a bit like putting grass on your car park. And these embryos are implanted. So I feel quite passionate about it because women are not being told that there's a risk of this, and it's irreversible once you've damaged the endometrium. And if you do get pregnant, you're going to see these huge increases of morbidly inherent placentas, small, well, potentially small growth-restricted babies. So we, in gynecology, do we have any obstetricians here? You're all in different sectors. You have to leave now, the obstetricians. So we should stop obstetrics, because if we sort out gynecology and make sure the pregnancy starts off in a healthy way, we can modify this. And just over lunch, I was talking to a young investigator whose interest is cardiac abnormalities and fetal problems. But the future should be, and you like this one, Steve, we said that sex is for fun and IVF is how you have a baby. So you do IVF, you genetically test the trophoblast, and you replace the embryo, and then we wouldn't need such a big off room for the fetal medicine people. We could then have a larger gynae contingent. That's what we need, Dirk, isn't it? We need more gynae. Okay, but I just really want to stress that, because I think what we're doing, we're too interventional in gynecology. Because it's easy to see pathology remove. You've just got to be careful. Think about what potential damage you may be doing, and that woman needs to be aware of that. So she's got a choice. I'm not saying you shouldn't do it, but just more information is always better. Just briefly to say here, really, again, from an ovarian perspective, IOTA is how you should scan and how you should make the diagnosis. From cysts perspective, they're not really a big problem for us. So again, do any of these affect your fertility? There's the link between endometriosis, of course, and impaired reserve. So there may already be a pre-existing issue. And there's also the debate of, do you remove an endometrioma? We had a really good conversation in the hub on Monday with George Condus about whether you leave or operate on endometriomas. But we know that when you remove them, you will invariably reduce reserve. So we've got to be really careful in terms of intervention for these things. But equally, I had a case before I flew here on Thursday of a lady who'd had an endometrioma punctured during her egg collection, and she got very bad pelvic inflammatory disease, very bad abscess, and has had 2 laparotomies and been very unwell. And unfortunately, that was bad luck, because it was a 2-centimeter endometrioma. But guess what? She wasn't told. So she was scanned, query hemorrhagic cyst, query endometrioma, query hemorrhagic, query, had the egg collection, got punctured, was given antibiotics, but now is very different because she's almost got a frozen pelvis. So again, if she'd have been told you've got a small endometrioma, what should she do? Most people would leave it alone, but her opinion now is if I was told, I'd have had it removed. So again, another example of information. So just I'm going to show you one picture only. We don't really use 3D very much for ovarian pathology because you don't need it, because the diagnosis is very simple in 2D, but you can make nice pictures. But it doesn't really change. There's one example possibly if you are trying to differentiate between endometriosis and hemorrhage, and I gave just an example here. So I think, again, if you are an expert scanner, you can be confident, but if you're not so sure, here you can do this. You can render this as well, so you can see the different sort of texture here, but that's endometriosis and that's hemorrhage. You can see the fibrin forming here. That's a retention clot. They're very, very different, so we should be 100% diagnostic, but I think in reality we know they will still see question marks on scan reports. We need to get rid of the question mark. So in fact, none of them really affect fertility. Probably removing them will affect fertility more than the cyst itself, but there is that concept in IVF, be careful about aspiration. Okay, so treatment protocol. So this is really now more on the functional side of ultrasound. These are the choices. Does anyone do IVF here? We've got some IVF practitioners. So this is, for those of you who don't, this is a sort of decision we have to make on a daily basis. And remember, IVF is a very competitive market. I know some countries it's very well government funded, but patients will ask around and they want to know. So they want to know what you're going to put them on, what protocol you're going to use, what drug, what dose, do you use any of these extra things? So there's a massive menu of choice and you've got to decide what to do. And I can tell you there is no consensus, none. So even in our own group, one of our clinics in Oxford will have a very different view to our clinic in London, to our clinic in Nottingham. And of course, we're all right, because we all know best. And this is the major issue, is do you use AMH or do you use antral follicles? So I've been having a battle with Scott Nelson for the last 10 years. So we always get invited to meetings, and I have to talk about follicles and defend the follicle, and he is an AMH fan. And AMH is winning by a long way, so we are losing out. The follicle and ultrasound has to fight back. So we're working with GE at the moment to try and do that, and I think it will. I'll say, I'm talking about PCO tomorrow, and someone reminded me that 2 years ago I promised that by this meeting we'd have pattern recognition for PCO, and we haven't. But I promise you we will in 2 years. But follicles will have their day again because of automation and because of AI. So there's going to be there is potential for us to be able to get a very accurate follicle count, more accurate than AMH. So don't give up on your follicles just yet. Now, this is really important. So the reason why follicles get a bad name is because of this. So I'm always told that it's all right for you, Nick. Okay. It's okay for you because you're in Nottingham, you've got fancy machines, and you're a GE boy, and they give you nice machines, and it's fine. And we've just got this, I'm not going to mention a company, we've got a poor machine, it needs to be charged up with a battery, but it's not the machine, it's the quality of the scanning. So this is just a very simple example. So there are a few guidelines on how to do a follicle count, how to measure. There's one international guideline. It doesn't mention ultrasound apart from you need a probe that has, including its bandwidth, 8 megahertz. But if you're using that probe at 5 megahertz, then you're not actually complying with the guideline. What does it mean that you have a transducer that's got 8 megahertz within its bandwidth? I mean, it's nonsense, isn't it? So the problem we've got, it's a bit like an AMH person not being dealt with by a biochemist of how you look at it. So this is just a quick video to show you how you can completely modify by changing your frequency. That's harmonics has been removed now. People say you must scan with harmonics, you must scan highest frequency, highest harmonic. That's not true. It depends what you're looking at. And you can see here when you switch the harmonics off, the follicles become more apparent. So if I'm looking for pathology and I want resolution, get up your bandwidth. But if I want to accentuate something, in this case fluid, then again using maybe a lower harmonic or a lower frequency will allow you to see those follicles. So scanning is incredibly dynamic. Every ovary, your right and left will be different. You've got to be changing your settings all the time. So I'm going to do a live scan tomorrow, but I've seen lots of live scans. I've seen lots of people all around the world scan. I'm amazed how they don't change the settings. Left ovary, right ovary, uterus, done. Then you're wasting the machine. So you may as well buy a cheap machine because it's all about the basics. So good 2D gives you good 3D, but you do need to modify it a lot. And this is just another example. So this is something we're working on at the moment. So this is the same ovary. So if you ask people, how do you get a better image? They're